Good morning, everyone, and welcome to the Belgian-German online meetup Digital Health. My name is Jessica Mantai. I'm based in Berlin, working for Flanders Investment and Trade, which is the business promotion agency of the northern Dutch-speaking part of Belgium. And together with my colleagues here in Germany, in Cologne and in Stuttgart, we are promoting sustainable international business in the interest of both Flemish-based companies that are focusing on market entry in Germany and also foreign companies, in our case, German companies who want to start operations activities in Flanders. And we all do this free of charge. As we all know in here, Germany took the lead on health application reimbursement when it passed its Digital Care Act in December of 2019 and established the term DiGA for reimbursable prescription of digital therapeutics. And all eyes were and still are on Germany. And so were mine and those of Lies Bogaert from iMac-iStart and from Katrien van Eekhout from startups.be. So together we decided to provide more information on opportunities and challenges for Belgian companies that want to enter the German market and wish to list their health applications as a DiGA. And then with the announcement in January that there will be an Belgian health app reimbursement scheme also coming, we decided to have this bilateral event with experts and companies from both countries sharing their knowledge and their insights with you. And here we are. Before I introduce you to Maren Lesche, our moderator of today, I'm happy to give the virtual floor to my co-organizers, Lies Bogaert and Katrien van Eekhout, to quickly introduce themselves as well. So Lies, maybe you want to start?
Yes, thank you, Jessica, for that nice introduction, and good morning all. Just a brief explanation or information about iMac-iStart and why we are organizing this together with the colleagues. So we are a technology accelerator in Belgium, and we support and also invest in very early stage startups. Actually, currently we have an open call for which companies can apply to join the 12 months program. And as actually healthcare is one of our main industry verticals, last year we had the intention to attend the DEMEA conference in Berlin, which of course moved to a more virtual environment. And so therefore we're happy that today we actually can join forces together with Jessica and Katrien in organizing this session. So looking forward to it. And thank you, Jessica and Katrien, for joining, and also the speakers for sharing their knowledge.
Yes, thank you, Jessica and Lies, and good morning to everyone. So I represent startups.be and scaleups.eu. Sorry, quite a mouthful, as this was the result of a merge between two organizations. We have joined forces to connect the Belgian startups and scale-ups with all the parties that help them grow and squeeze their time in their development. These can be investors, corporate buyers, or corporate innovation partners, other startups, incubators, accelerators, or even talent. So personally, I'm responsible to do that on an international scale. And we have an agreement with Flanders Investment and Trade to do that. And we often collaborate with iMac-iStart as well. So we work for the whole Belgian startup and scale-up community as long as they are technology-based. We are region and industry agnostic, but healthcare startups are one of our major segments. Therefore, we are very happy to be involved in today's events, and also as we believe that Germany and Belgium can exchange a lot in their current stage of adoption and recognition of digital technologies in outpatient care. So I wish you all a very fruitful day.
Thank you, Katrien. So then I will give the floor to Maren Lesche. She's our moderator, and many of you probably know her already. She's an ecosystem builder by excellence. She's a startup expert in the fields of digital health, IoT, and AI. And next to being the founder of Startup Colors, which is a startup and innovation consultancy company. She is also head of incubation, I think since 2019, of the Vision Health Pioneers Incubator, which is a Berlin-based healthcare incubator or startup program, which educates and connects healthcare companies in Europe. So I'm very happy to have you on board, Maren, and it's up to you now to introduce our speakers of today.
Thanks for the warm words. I see a lot of familiar names in the list of attendees. Welcome as well for a powerful session of talks, but especially conversation. So use the chat, please, to ask your questions while our speakers are sharing their knowledge. There will be time afterwards to also ask all the questions you have. I think it's something that we really want to encourage. We want to have a dialogue. We want to have fruitful meetings. So use that chance to get first information, but also dig deeper. We will have 2 presentations in the beginning, starting at 9 or 10, and I think we are right on time, by Jonas and Alexander. I will quickly introduce Jonas, and then at 10, we will dive a little deeper into how young companies actually did it, how they obtained the DIGA, what they're doing right now. And I think what's also quite important as well is how does it work across borders? What does it mean for a Belgian company to actually try to enter the German market, but also what are the chances and opportunities for German companies to enter the Belgian market? And I think it's quite important to understand that there are a lot of similarities and a lot of opportunities coming up. Let me introduce you to the first speaker, Jonas Albert. He's lead of Health Reality Lab Network. And I think what's interesting is when I digged a little deeper into him, he was like, I'm DIGA obsessed. And you know, DIGA is not that old. DIGA started in 2019. And there's still a lot of unclarity about, you know, your opportunities with DIGA. And we have a true expert here. So Jonas worked in multiple forms, I think, in Germany. He started as a paramedic at German Red Cross, so he actually did the groundwork as well, worked for multiple organizations and also joined IMEC. And I think the advantage of having Jonas here on stage is also that he knows the Belgian market quite well. Right now, he is project lead at the Health Reality Lab, and the Health Reality Lab is super interesting from my point of view, because it helps young companies to enter the German market, and it's also an organization that does it as an NGO, so a lot of support and a lot of knowledge for free. And I would like to hand over the stage to Jonas. The stage is yours, and we're very much looking forward to
Thank you very much. Oh, sorry, I don't hear you anymore. Can you still hear me?
Yes, I can.
Okay, fantastic. Thank you, Maren. Okay, I'm just going to quickly share my screen. Thank you very much for the kind introduction. And you should see my presentation now. All right. Okay, is everything all right with the presentation? Can I commence?
Yes.
Okay, fantastic. Thank you so much for the introduction again, Maren. Yeah, as already said, I'm here for the Health Reality Lab Network. And before I start, I'll just give you a very small introduction just to frame a little bit, why am I talking about this? why do I claim to know the things I know? So we're a project financed by the German Ministry for Economic Affairs. Our goal is to support and foster economically sustainable business models for digital health. That's the main goal overall. And that meant, because we had the new Digital Care Act coming into force last year, that we were really going hard on supporting different companies free of charge regarding them joining the DIGA fast track, applying to become a DIGA, to become reimbursed in Germany. Just to give you some rough numbers, so some overview. So sometimes I'll just tell you things from experience that are not directly in the laws here. And I just wanted to give you a little bit of a frame where this is coming from. So we're currently having over 70 startups, all digital health startups within our network, and over 40, I think we're at 45, 46 at the moment, are applying or are at some stage in the DIGA fast track. And from the first 15 DIGA manufacturers that have either complete or provisional listing, we accompanied 5. So I hope we can keep this quota alive. And yeah, the project officially ends the end of this year, but we're just actually yesterday we had the first seating of founding a Verein. That's a German legal entity. It's like an association. And this Verein has the goal to continue the work that the Health Reality Lab work is doing this year, also next year, to still have the chance to offer support to startups free of charge. All right, but before we go in, healthcare systems, no worries, I will not go too deep into this, but these are the two countries we're talking about in a schematic display. Who can tell which is which? Oh, no, I'm joking. So the left is Germany, the right is Belgium. So they look quite different here in the schematic, but they're actually super similar. And before we start, I just wanted to give a very quick introduction why they're so similar and why it makes a lot of sense to compare the digital health reimbursement legislation in both countries, and why it also makes sense potentially for companies to cross the border into the other markets. So to start with Belgium here, Belgium has compulsory social health insurance, low coverage for private insurance. There is a care catalog that's governed by a central entity, and outpatient care is mainly delivered via private practices. So you have kind of single entities, doctors working independently do that, and all care is paid via reimbursement and co-payments in some cases. And as you will be able to see, Germany is virtually the same, at least in these categories. There are differences. Some of them are quite interesting as well. For example, although the reimbursement system works very much the same, there are smaller things that might impact business models. For example, or my favorite example is in Belgium, you pay 30 euros out of your own pocket every time you visit a private practitioner, every time you receive outpatient care. So Belgians, at least in my personal experience, have a kind of a slightly different relationship to spending a little bit out of pocket for healthcare related services as compared to Germans, where it's usually a money-free thing. Except when you go to the pharmacy, you get drugs, that's kind of socially accepted. So it's these small differences in perception that might also impact different business models. But that just as a general framing. On paper, both healthcare systems are quite similar, like the mutualities, the Siegenfonds, and the public health insurance or the social health insurance in Germany work in a very similar way, and also doctors are organized in a very similar way. So chances are good that you will not have to change so much regarding your digital health innovation in order to cross the border into a different market. That just as an introduction. Now we really go into Germany, and I just wanted to give you a very quick overview regarding what's the current situation. So Germany, and that's an honest opinion from a German, is basically has been lagging behind quite significantly regarding digitization of the healthcare sector. But that changed with the last legislation period that's now coming to an end. So we had a very progressive Minister of Health. And this is just an excerpt of the current healthcare legislation that we have. So the most important thing at the top is definitely the Digital Care Act from late 2019. Did two things. One, reimbursement of DiGAs, which is a specific type of digital therapeutic digital service, was reimbursable now. That's the big thing. But also, and that's a secondary part that's usually often forgotten, but it's, I mean, almost the same importance, social health insurance can now form investment funds, so analog to VC funds, that can directly invest in health innovation. Then we had the Patient Data Protection Act, which laid a lot of the groundwork in 2020 to really pursue having a countrywide electronic health record, or electronic patient record, to put it in the correct technical term. That's still ongoing. That's also the point where I'm the most concerned about, because a lot of innovations will rely on having good interoperable data infrastructure for health data. But at least there is now a better and more solid legal basis for that. Then also important maybe for some of you, because the DiGAs are really, like the digital care was really on the outpatient innovation, but for inpatient environments, and by that I mean mainly hospitals, we also have the Hospital Future Act. And the Hospital Future Act instated a huge fund where hospitals can now apply to in order to get investment money from this fund to conduct digitization or digitalization projects for digital innovation. Several categories, that's quite broad, the scope of that, but that will most likely kickstart in the next 3 to 4 years a significant wave of digitalization projects within inpatient environments in general. And now upcoming this year, there's the Digital Home Care Modernization Act. By the way, that's a funny thing in German. It's Versorgung, that's the word for care, but Versorgung usually means only healthcare. It's very difficult to translate anything care related into English because care means care overall, but then the specifications into healthcare. So don't be alarmed when sometimes home care, healthcare, and care are used in translation interchangeably. That's a little bit confusing. But the big thing about this Digital Home Care Modernization Act is that you will have reimbursement of DPAS. So that's digital services, but that are targeted at a care and as in nursing care or home care environment. And there are also some minor adjustments to the Digital Care Act. But for today, and especially for the sake of comparing the current developments in Germany with what's planned in Belgium, we will really focus on the Digital Care Act. But just to give you a little bit of a frame, there's a lot of movement currently in Germany in that regard. It's inspiring, actually. It's great to see. Just to give you a little bit of an idea, why is the introduction of reimbursable digital therapeutics, why is that such a revolution for Germany especially, and probably for other European countries as well? And I thoroughly hope that other European countries will also follow the German path regarding the legislation. And maybe look what worked and what didn't work, and then kind of cherry pick what went best. So what you see here are the three business model options that were eligible for Germany before the latest digital health legislation came in. So, I mean, and this is, by the way, this is a gross simplification. I mean, you could make this much more differentiated, and please see these only as a very basic overview for the sake of time. So the rule of thumb was, if your digital health innovation provides some sort of cost containment or marketing value, but that really depends on the health insurance, you could go to the public health insurance and make a selective contract with them. They would offer this done. Or you have some optimization, which also in the end goes to revenue optimization for healthcare providers. You would do a service contract, usually with big clinics. That's the status quo. And then you have the individual value for out-of-pocket payers. And these are really business models that usually work best in the US environment. But in the German environment, there is usually not a big willingness to pay out of pocket for these types of solutions, because, as I said initially, German patients are not really used to take money in their own hands. But now there's this fourth way. So if you provide medical and or structural value, which is something new, which I'll explain later, you can apply with the BfArM, that's the Drug and Medical Device Authority in Germany, and go through the DiGA fast track and become a DiGA. So become reimbursed in the system, patient doesn't pay anything, and prescribed by doctors, which is a massive improvement for digital health business models, because now you can finally say, hey, I actually can really get reimbursement for the things I'm actually good at by improving patients' lives, by providing medical value, by optimizing really care at the point of where the care is received. All right, that's the process. And a significant part of the process that's often glanced over, I would really directly highlight in the beginning. So the process in general goes from left to right. You apply at the BfArM, and then you have two options. You can see at the top, there's the final admission. That's very close to what you would do if you would develop a drug or a classical medical device. So you make a big study, you collect all the evidence, you go to the administration that's responsible for greenlighting you, and then you tell them, hey, this is my evidence, and they say all is cool, and then you get admission, you get accepted into the DiGA directory, and then you're reimbursed. But that's not really the revolutionary part, because in the past, the majority of healthcare startups did not have the financial means to conduct a 2-year study in order to really provide clinical evidence for their product. And this is where this part comes in. You can basically make a small study, even one-armed, with 30 patients, and then have preliminary evidence that just has a tendency or just makes it plausible that your health innovation has certain medical or structural value. And then you can go into the preliminary admission. And this preliminary admission means you have 1 year time to conduct a study that proves your product, that your product has the additional value. But during this 1 year, you're already completely reimbursed by the social health insurance system with a price that you can more or less govern by yourself. These prices are currently extremely high. So we're looking at a reimbursement for around, usually between 350 and 500 euros for a 3-month prescription period. That's extreme. There'll probably be legislation that kind of puts a cap on this, most likely in the near future. But at the moment, you have a really, really tangible solution to co-finance your evidence generation, which you didn't have before. And for me, that's something that's absolutely groundbreaking. Usually, the most things, however, go wrong during the application phase. So we have currently a lot of digital health companies that are very agile and that are also often pressed from their investors to do things a certain way, and they usually do not have the farsight, but also not the experience, and sometimes to make a proper application there. And hence, I'm really looking forward also to the later presentations of the other two speakers who already went through the process, and to really let you know what are the difficulties in applying. That's also something where we support different startups in many ways to provide the necessary information, to make the application, to gather the preliminary evidence as well. What's important here is also the BfArM does consultations, and these are really integral to the whole process. So before you apply, go there, have a consultation, but also preparing this consultation is quite a particular thing, because the BfArM is also very particular in not giving advice, but just telling you no or yes. So that's also a very important part of the process that's usually left out quite often. What makes you a DIGA? I mean, I've been talking now very long about what's the setup of the process, what's the goal. This is quite straightforward in some parts and not so straightforward in others. So in general, a DIGA is a medical device class 1 to 2A that you have to be. And then we go into a territory that's a little bit less easy to understand. So there's something called the digital main function. I call it usually elusive digital main function. So what you have to see is it's very important that you have a product that's really digital by nature, and that it does not just enable another non-digital or analog service. For example, if you would just have an app that enables to make a normal lab test quicker and more efficient, that's not a DIGA. It has to really be a treatment component, like instructing patients to do something, exercises, take your medication, and so on, by itself. And it has to achieve a medical purpose by doing that. At the same time, it's very important that the patient is using the DIGA more or less by themselves, or only with very little interference from the doctors. And a lot of digital health companies stumble over that because they have the doctors very much integrated into the process. But then the BfArM claims your software itself is not creating any additional value. It's just facilitating contact to the doctor. And hence, it's also very important that you can't be telemedicine at all. Regarding the purpose, I mean, that's very straightforward: detection, monitoring, treatment of disease, etc., and so on. And it's very important in that regard that you associate yourself to one of these categories. And lastly, of course, it's also unfortunately not possible to have primary prevention within the frame of a DIGA, because that is governed through a different body of law in Germany, and that's also very differently reimbursed. In general, not as well as DIGA. However, secondary prevention can be an option. That's especially important regarding price negotiations, by the way, because what I didn't talk about previously, at the end of the fast track, so when you are in the registry, you're technically eligible to be reimbursed, but only after you went in there a completely different process starts, where you start negotiating a price with insurance companies. This here is just an overview. I will not go through each and every one of them, but this is a general overview regarding the so-called positive care effects. So when you want to apply as a DIGA, you have to kind of group your outcomes into these pre-made categories. So when you want to, just imagine you have a physiotherapeutical DIGA, it instructs patients to conduct exercises at home, and then you reduce pain in the joints for a certain indication, for example. And then that would be, for example, a medical benefit, and more specifically, an improvement of the state of health. It's very important that you adhere to these categories, and any positive outcome you create is within these categories. The first group, the medical benefits hereby, is very straightforward, because there's morbidity, mortality, and quality of life is something that every one of you who already had contact with clinical trials for drugs or medical devices should be very familiar with. And there are also a lot of measurement instruments which are validated, which is, by the way, mandatory. You have to use for these only validated measurement instruments. The second part, however, that's really new, and there I would really be interested also in the Belgian counterpart. Are there laws in place, or are there mechanisms in place to also mirror these more, let's call them in quotation marks, exotic effects that are there? Because here we're really facilitating access to care. We have patient safety, we have illness-related difficulties in everyday life. So we really have effects that have not yet been measured as thoroughly in clinical practice, because they were not reimbursable. However, they have a lot of cost containment, a lot of patient relief potential. But here, and that's also really the interesting part for us, when we support startups here, we really have to be creative and forge sometimes new measurement instruments and validate them appropriately, and also really see what benefit do I have, what type of adherence effects do I have, for example, or what does it mean to coordinate treatment procedures, and how can I measure this in a comparative study. That's just to kind of clarify the narrative a little bit more. So the backbone of every fast track argumentation, that's really where the point at which you have to arrive. So you always have to be able to say, so through my DIGA, patients with the diagnosis something something, so that always has to be defined by the ICD-10 coding system. So patients with this diagnosis XYZ are getting healthier or are deteriorating slower or are receiving better care structurally through my product. And I'm measuring these effects with these parameters, and I'm measuring these parameters by deploying this measurement instrument, questionnaire or a different measurement instrument. So for example, just very quickly, your outcome is the BMI, and that's if you treat obesity patients with your DIGA, and then your positive care effect is improvement of state of health, and the measurement instrument is a certified weight scale. Usually then it's patient reported in the end. Except if you have a Wi-Fi connected scale, but that's, that's a different discussion. There are a lot of interesting things you can do now with connected devices regarding measurements for these studies. Outcomes for quality of life, that's very straightforward. EQ5D, the same as you would do in a clinical study. However, quality of life has not been as prevalent as a measurement instrument in Germany in drug studies, because we do not use quality adjusted life years in Germany. So that's kind of a new thing as well, which I very much favor. I think that's a great idea, because sometimes you cannot really model your outcomes properly with like smaller measurement tools, and sometimes the quality of life is just the appropriate thing to measure. And then the last one, that's an example for one of the structural effects, the time savings through conducting rehab at home. Then you really have to measure how high is the average time saved I have per patient, and then model that according to the outcome that you would have compared to someone who's just receiving care as usual. And finally, I would just like to quickly describe, if I have Wunschkonzert, I don't know if any of you know this expression. So kind of, you go to a concert and wish what they play. So if I would be able to paint the ideal process, that's what it will look like. So just to very quickly go over it, also to have you, after this presentation ends, I assume that it will be sent around, to just have this kind of as a little bit of a cheat sheet for the overall process to make your own roadmap. That's really the intention of this. So we have in the beginning, what are my positive care effects for which patient population? That's very straightforward. And then you do two things. You draft a pre-study. So remember, in the beginning, I said you need some form of preliminary evidence to apply for the fast track. And then you draft the evaluation concept. You consult with the BfArM, let them know if your concept, if your plan is valid. Then you finalize all the documents, and then you adapt your software and your hardware for the last time. That's extremely important, because during the process, during any evidence generation, your app development has to be halted. Well, it's a bit more complicated than that, but any component that has impact on the care effects you provide, that impacts the patient interaction in a meaningful way. So just changing colors would be no problem, but adding a new treatment model would. That changes your DIGA, and that makes all the evidence you gathered before worthless. I know that's a huge impact on your strategic roadmap usually, because you have to freeze development, which you never ever want to do, especially if you're a startup. I completely understand, but you have to take this into account. Because you also can't change a drug compound after you gather the evidence, and that's kind of seen similarly here. And then phase two starts, where you really start with the evidence generation. So you conduct your pre-study, you adapt the documentation last time, and then you send the application. Then the 3-month phase starts, where the BfArM will send you different reports. Hey, we need info on that, or this is not good enough. You adapt everything, and then you hopefully get the preliminary listing. The minimum amount of time for these two things is if you're ridiculously good, if you're really, really fast, you can do this in 6 months, but that never works. So 9 months for somebody who's fast and well prepared is, I think, realistic, but then really has to be everything in place. So currently, a lot of DIGA manufacturers that we're currently accompanying, the fastest ones really did it like with a lot of pre-preparation already in like half a year, but 9 months to a year is more realistic, especially because you have like multiple hurdles to overcome. Okay, that was it. I know that was just very high level at some points, but I thought it would be a good idea to give all of you a specific overview on what's going on. I'm looking very much forward to the presentation about what's going on in Belgium. And I really hope that there are a lot of synergies between the two processes, that maybe we can even transplant evidence from one country to another, because the care contexts are so similar. And I thoroughly hope that, yeah, I could tell you some new information. I'm looking forward to the discussion and the questions later. Thank you very much.
Thanks a lot, Jonas. And while our next speaker, Alexander, is getting prepared, there are a few questions in the chat, and I just want to highlight one. Stephen van Hoof says, it seems contradictory that telemedicine is excluded, but the device should be used by the patient alone or in tandem. Can you explain?
Yeah, so telemedicine is the facilitation of a conversation or a consultation that is taking place between a medical professional and a patient, and it just replaces the face-to-face interaction. The DiGA should create value on its own. And I really would strongly advocate for a correct nomenclature regarding what telemedicine is. Telemedicine is just the communication, but telemedicine should not have a treatment value on its own, because that's what the doctor is doing here. That's very important. The DiGA, however, is really a digital therapeutic, so it has therapeutic value on its own. But if you just use a DiGA to facilitate contact to a doctor, then there would be the claim that your DiGA itself is doing nothing and the doctor, through his or her treatment, is doing all the work. Telemedicine is often used to describe the whole digital health sector, and I strongly advocate against that. Telemedicine, for me, is really only Skype between patient and doctor. Of course, you can have nice add-ons for Skype to see more data, to have bigger insight into that. But apart from that, communication or replacing face-to-face interaction with a healthcare professional, telemedicine, therapeutic value on its own, digital therapeutic. That's where I put the line. And I don't think there's a big contradiction. However, I can completely understand that the terminology can be quite all over the place and confusing sometimes. That's, by the way, also the no telemedicine stuff. That's an aspect that a lot of DiGA manufacturers stumble over, because they, oh, is this too much doctor? And we had the doctor included because we thought it was, I mean, usually it's very good for the patient to include the doctor, but unfortunately within this legal framework, it's not possible.
Thanks for answering, and I think Stephen also sent a message that answered the question that he had. Keep asking questions in the chat. We will also summarize the questions later on, and I'm very much looking forward to our next speaker, because I think there will be more questions also coming from different sides. Alexander Albrecht is our next speaker that will highlight the Belgian part and also highlight the similarities and how the project and the process looks like for reimbursement in Belgium. Alexander is part of Agoria, and Agoria is the management partner of mHealth Belgium. And I think he will tell us a little bit more. I think mHealth Belgium was founded in 2019, so it's not that old. And there are a lot of companies, and especially also young companies involved that use your services and the network to dive deeper into the new reimbursement scheme. Just some information about Alexander. He has different degrees in medical imaging, a bachelor in medical science and a master in management in biomedical science from Leuven. And I think you're kind of 100% Belgium. So we're very much looking forward to that. And I think what's very interesting is you are not just coordinating the mHealth Belgium initiative, but you're also a co-lead of the initiative IA and EI for health, so a very technical term. And I'm also very much looking forward to know more about interoperability. I think this is one thing you touched, and I think the treatment of data is something that is quite important for any cross-border activities. The stage is yours, Alexander. We are very much looking forward to your presentation.
Thank you for the nice introduction. Indeed, so if all went well, you can see my screen right now. And I'll try to give you a small introduction on mHealth Belgium. And indeed, it's a quite young initiative. Well, as the initiative itself is quite young. The history before that was a bit bigger, I would say. But we'll get into that very shortly. But first, let's take a look on how telehealth is being looked at within Belgium, because this is maybe a tiny bit different. Rizif Inami is looking at this at the same way as presented here. I have to be completely honest, this slide is I took it from a presentation of Rizif Inami, but it gives you quite a good idea where the focus points are in Belgium, and you can see that mobile apps are one focus area there. But we also are looking into teleconsultations, tele-expertise, and telemonitoring. And you can see the small diagram here in the lower left corner. And you can see this small overlap between teleconsultation, tele-expertise, telemonitoring, and mobile apps. And this is done on purpose. We see a crossover between all of those with the apps, with teleconsultation, and they are starting drifting towards each other, more or less. But this will depend a bit on the decisions that Recife and me will take in the near future and in the coming future. But if you want to apply for ML Belgium, this is already a good notion to have, and knowing that these are coming closer together, and an exchange between those will be very interesting to see. On the right hand side, you can see a more academic approach on how telemedicine can be looked at. This is just for just information. But going into the topic of today, being mobile apps. We have ML Belgium. So the initiative really focuses on the mobile apps within Belgium. It has a very fancy name, ML Belgium. I think it's a pretty logo it has as well. But the reason why this is conceived in the past is actually pretty logical. As you all know, applications are growing rapidly on the App Store, and just about almost every application, you have to do a quality check. We have to look if you want to download, whether it's a game or whether it's an application that really is useful. You always have to do some sort of a quality check. You can see different kinds of quality within applications, and you can see with medical applications, there's differences there as well, and it's very significant. Even there's a high difference between the applications that actually have a therapeutic or some sort of real life benefit towards the health of a patient, and you have applications that are just there for fancy reasons, and there's nothing wrong with that, but you have to inform your public very good on this, on when to use an application and when you would rather not use an application, or whether the application serves the purpose that you want to achieve from the application or not. Now, let's look a bit in the history, because this is the problem that was being noticed already in 2015 on applications, and the digitalization of Belgium, or its healthcare at least, is already something that came into place quite a while ago. And they conceived the eHealth Roadmap 2.0. Actually, it was an action plan consisting of about 20 action points, and action point 19 was really focused on this topic here. Now, this is already 2015. I don't have to remind you, this is already 6 years ago. In 2016, they started the proof of concept phase, at least. So they invited 98 projects and were submitted, and 24 of them were selected. They went through a whole process, a lot of things being tested. I won't go too much detail there, but of all of those pilot projects, this validation pyramid that will be the foundation of everything else that I will be talking about later on, was actually the structure that was held upon this entire process. And this was already in 2018, and the launch itself was being done in the summer of 18, and the platform went live in January 25th, 2019. Now, this is the platform that we can see today. Does it mean that it has been static around the years? Well, absolutely not. We changed quite a bit on it with the different parties, and I will show you later on who is involved in this. And as mentioned, why action point 19 focuses on mHealth? Well, it's quite clear. I already gave you the answer, and that is there was a need for a framework, a good framework going into quality, as I already mentioned. But privacy is a second very important issue. Some applications are really well aware of the sensitivity of the data that they will be processing, and hence they will have good processes to protect their privacy, and others really don't care. And it's blunt to say that like this, but unfortunately that's the case. And of course the evidence as well on will it help the patient with his or her problem having it. Now, focus of the ML Belgium part, as you know, and as the previous speaker already showed you, Belgium is a quite complex country as well. And this is reflected on the ML Belgium platform. But having a lot of stakeholders doesn't really necessarily mean it's very complex. Belgium can and fall into this trap that things are getting really complex. But I think here the beauty is the collaboration between all these parties here. And to go even further, it's not only the Belgian authorities that work together on this ML Belgium platform. 2 federations are working on this as well. So my federation, the Technology Federation, Agoria, and then the Federation for the Industry of Medical Technologies, BMedTech. So we are coordinating the platform, and responsibility is more or less with the authorities that you can see here. I will go into more detail which authority is responsible for which level, and this will be something that you will see in the pyramid as well. We have 3 levels, and everybody will play a role within this. Now, the platform, what is it exactly, and for who is it, and what does it really do? This is a really pragmatic slide, I would say, but this is just basically a website. It is in 3 languages, and I'm not going to bore you with all the details on the language, but an interesting thing here is that English is the 3rd language, and German was out of scope, and this is a bit unfortunate for this platform here, for this audience here. But the reason why English was chosen is actually to attract international companies. So it's not necessarily only for Belgian companies that understand and speak and operate in Dutch or French. No, it's actually for multinational startups. All companies that are active with an application in Belgium are eligible to apply on ML Belgium, given that they meet the criteria. The goal itself of the website is, as mentioned, information for the broad public, patients, healthcare providers, and institutions, because they will all have different questions. And we try to condense all of this information on the website that everybody can have his or her information found on the website. And you wouldn't believe, because we have a contact form there as well, what some people ask you in there. But I think this is a good thing, since we are having this mission on informing patients and the broad public on applications for medical purposes. What you do need to know here is that it's not a full market scan. It's not mandatory to be on ML Belgium. This might sound a bit paradoxal, but it's not mandatory. What do you get in return is the obvious question. I can hear it through my computer, everybody thinking this question is actually, if you want to get reimbursed, if you want to interact with the authorities, you should go through ML Belgium. So this is a very important part, but you can operate entirely next to the platform. And it's company driven, as shown. It's being coordinated by 2 federations, industry federations. So it's more or less company driven on the higher level, and on the smaller level, you can see the same thing due to the fact that the company itself is responsible for all the information that you publish on ML Belgium. And I'll show this later on. There is a big difference between the objective criteria that we'll be asking, and I will go into more detail here, and the information that is, I would say, subjective, more about the application itself. We allow competitors on the platform. It is on the manufacturer's side then to differentiate, to sell his application. And I know it's a bit of a wrong or a dirty explanation on selling this, but in the end, it's the market that will decide which application that is best. So the way that you can offer your application is really important as well. However, with the criteria that are in place, we can safely say that we have companies that are willing to be compliant to rules and regulations. And at least they have met minimal requirements and minimal levels of requirements here that are formalized. And that is important. So not all can go on the platform and do whatever they want to. So this is ensured, and everything that is on top, that is on the company. Let's look into the pyramid itself. So as you can see, it has 3 levels, and every level has a basic idea, a key sentence, a philosophy behind it. The reason being, for a big part of this, is that every level is a responsibility of a Belgian authority. The first one, for example, is I am a CE certified medical device. The CE certified medical device is responsibility of the federal agency in Belgium. What you saw was Fach in Flemish and FAMPS in French. To go level up, we have level 2, I am safely connected. Safely connected, there they mean I am interoperable. I share my data with other applications, with other governmental parties, with other hospitals, with other systems in general, and I identify the patient on a correct way. Authority here that is responsible is the eHealth platform. They are responsible for this matter, so it's very logical that they took responsibility of level 2. A level 3 is I show socioeconomic evidence and I get reimbursed by Risiv. The answer is here already noted. Who is responsible here is Risiv Inami. And so these those three parties, are responsible for the 3 levels on the pyramid. Already something I can say here, it's a pyramid. And the reason why it's a pyramid, this is chosen just because it's a pretty shape, but it has a philosophy or a meaning behind it. You can see that the lower level, level 1, is much broader than level 3. So more apps will be eligible for level 1, a little bit less on level 2, and a little bit less on level 3. Is that an issue? Absolutely not. Some applications will be fairly okay with just having level 1. I think about applications that serve some kind of device, or that they have a business model that is not reliant on the application itself, but they want to show towards the broad public, we are here, this is what we do, and these are our credentials on the platform. So you can see that it's becoming a goodwill, and then you have the effect that ML Belgium starts to be like a quality label. It isn't formally a quality label, but you can see that hospitals in Belgium start looking towards this, start asking the question, are you an ML Belgium? And from time to time, this question isn't even relevant, but it's being asked, and that's a good thing again. We will go a little bit into the more detail of the criteria itself. I won't bore you to death with all of these criteria because they're quite technical from time to time, but I will guide you through it and give you the centralized idea that if you want to apply in Belgium for ML Belgium, that at least you have a working knowledge on the criteria itself. The details we can discuss later, and this is something that we do as well. We go into discussion with the companies and help them through this journey on getting on ML Belgium. So the first thing, and this is where we draw the line, or the line was being put, in fact, in the past. You have to have a CE declaration as a medical device. And for some companies, this is already not feasible due to the simple matter that it's not a medical device. Do they have everything else? Yes. Are they a medical device? No. So this is a choice that had been made in the past on ML Belgium. It will only have medical device CE declared companies there. This is something that you need to do. You have to draw the line somewhere, and for Belgium, we draw the line at that point. Next, the second criteria is a voluntary notification. Well, it says voluntary because of the fact that it's voluntary to do so, but if you want to come on the ML Belgium platform, obviously it's mandatory. You can see a screenshot of the site here, and why is that? Because this is in full transparency. So the federal agency will look at the CE certification. They will check some things with you, and in the end, you will be published on their website as a mobile device. You will get a number, an official number, and this official number will be published on the ML Belgium website. Third, and the last criteria for M1 is you have to be compliant with the GDPR regulation. Am I going to check whether you are GDPR compliant? Well, no, but you are telling me that you are, so that's fine by me. Does that mean that I go lightly on over all of this? Well, absolutely not. But my role here, and the one of the colleagues on ML Belgium, is more as a notary. So we will be looking if the documents are there, and are they there? Good, then you're good to go. But your responsibility itself lies with you as a company. I have a small example here on how it looks like. So you can see a small description of the application here, and this is something that you can write yourself. So you're good to go with whatever you want to write there. You can see, okay, this is level 1. You can download it on the App Store, Android. It's available as a web application. The languages that it is available, visit the website and visit the company. This is the subjective information. You have much more of that. You can see the main purpose. You can target audience. You can see some categories as well to be efficient on the database. Your pricing model, everything else that you can imagine, you can write in there. Am I checking this? No. Am I checking whether the right language is on the right box? Yes. This is something that we'll check. This is for the subjective criteria. If you want to go to the objective criteria, this has been shown as well. And this is on the tab next to it, additional information. You can find all the information of the applications published on ML Belgium right here. And as I mentioned, Transparency, communication towards the broad public and everybody involved in this entire care pathway should have access to this information. So we show this, meaning you can see the CE certification of the application. You have to provide this on the website, and it's downloadable by the general public. You can see this one here is a self-declaration, but depending on the new MDR, so this is still one on the MDD, and we indicate this if you're on the old regulation or on the new regulation. But you can download it, you can see the details, you can see until when it's valid, you can see what class of medical device it is, you can even see the ISO standards that they have. These are the ones that are applicable towards mobile health applications. And you can upload them to the platform, and you can then see if this is not the case, but they will have this green checkbox here. For example, if they would have the risk management of medical devices, then they will have a check here as well. So this is all visible. You can see the numbers here of the federal agency. Is the general public going to look you up on the platform? Probably not. But maybe a healthcare provider will do so, or maybe an institution will do so. And if nobody else does it, or if nobody does it, at least it is available and it is transparent, and you can see this. Third thing, GDPR, what are you doing with the privacy? Well, the company declares explicitly that you are compliant with GDPR rules. Again, this is your responsibility. And furthermore, the company declares that the data is stored in the EU only. Is this not the case? That is not a big issue. It will just not have this green checkbox here. But again, this is information that the broad public wants to know. And so we publish it. And then you have the third tab, and there you can show some pretty pictures of your application. I'm sure everybody that has or is developing an application or has an application will be very proud of the pretty pictures that they have. So feel free to show them. You can even have your YouTube movies here, instruction manuals. You can all have it here in order to show that your application is the best in class for your pathology. But at least that you can do so. Now, level 2. I'm counting on the fact that you're writing if you have questions in the chat box, so because I can't see them here. So I'll just continue on. Level 2 is a connection with eHealth platform. And as mentioned, it's a pyramid. And furthermore, it's not a buffet. So you have to have level 1, 2 as well to go into level 2 and to go into level 3. So you can't say, oh, I'm not bothered with level 2. I just want level 1 and level 3. This is not the case. So it's a pyramid. You have to fulfill all these criteria. So the first criteria to be level 2 is be compliant with the rules and regulations of level 1. Now, level 2 is being tested by a risk assessment, a self-risk assessment. I won't go into detail how the process itself works. I would take this offline with you if you are interested in this. But what I can do is run you through the criteria that are being tested by this self-assessment. There are 6 criteria for level 2. And in my opinion, I would say this is the most technical one, because here we will really be testing the interoperability, the identification of patients. So this is a crucial step. This requires some back-end fiddling for some applications. Some are just plug and play. It depends a tiny bit. But if you see the 6 criteria, the first again, and the last one is again GDPR. So the first one we will be testing, are you a GDPR category 1, 2, or 3? Meaning, are you processing personal data, and is this personal data is sensitive information? The experience in my experience at least is a lot of them are GDPR category 3. We have some 2s as well, but most of them are handling sensitive personal information. I think all of you already can understand why this is. Criterion 2 is the use of the social security identification number within Belgium. This is a bit of a particular one. If you don't use this, then you can't go on N2. The reason for this is that in Belgium, all of these instances, and we have quite a lot of them, are communicating about patient data with one unique identifier. And this is our social security number. So I think the Belgian people in the room already know what number this is. For the foreign people, this is a number that we get when we are born. I think in Germany they have a similar number, but this is the one that is actually needed to be used. You can vary in the degree on how you embed this in your application without going into too much detail, but you are required to use this number to exchange information with other systems as well. So official systems, governmental systems, but also your colleagues or competitors. Because the eHealth platform wants to avoid that applications are data islands, and they are not sharing, and they are just isolated on their own. So this is what we want to avoid. They want them to interconnect at least at one in one point of view. The user authentication. This is the hardest one, I would say. And if you are interested in going on to M2, read criterion 3 really carefully. I think it's the one that I received most questions on. But the idea here is, how are you going to authenticate the user of the application? See, it's app user. So this can be the healthcare provider, it can be the patient, this can be a caregiver, depending on how your application is built. You can use two systems, or you can use a service that is being provided by the Belgian governmental e-health platform, or you can use your own system. I can see that they are mixed for the moment, most applications. And this will be decided by the fit at your application and the strategic choice that you want to have. Criterion 4 is if your application requires a verification of the relevant characteristics and the relationship between the app users. This is the therapeutic relationship and informed consent between patient and medical healthcare provider usually. If this your application requires this, you can use this service again from the Belgian governmental e-health platform. Criterion 5 is interoperability. Do we require some sort of standard, a specific standard? No, but you have to use standards. So whether it's HL7, whether it's Khmer SNOMED CT, you can choose this, but at least you have to indicate which one. And criterion 6, compliance with GDPR. Now, how does this look like on the website? So the basic information stays the same, but you went to M2 and then you will see new information published on the website. Just give you a small overview, and I will pick out the most important ones. So you can see GDPR category 3, they handle sensitive personal data. They use social security numbers, and they use their own identification system fulfilling the M2 requirements. They use the Khmer standard, and they explicitly comply with GDPR compliance. So we show this again, and this is an easy, understandable language, because most of you know really well how this works, but the general public isn't much aware. They know the term GDPR, but what it actually means is more a difficulty from time to time. I hope this is clear on how this is being linked. You know, there is a process behind this with a self-assessment to test these 6 criteria and to get your information right here. And know this is, I would say, the most, until M3, this is a quite time-consuming one, depending on the nature of your application. Now, level 3, I think this is the most talked about one for the moment. You have to know this was launched in the beginning of 2021. And why is it so important? It's financing. It concerns money. So we all know this will create some discussion. So what are the requirements in order to get your dossier ready to file for reimbursement of your patient trajectory? First of all, meets basic criteria level 1 and level 2. This is something I tend to repeat them quite often, but just to have you really on the same page here. You have to have a demonstrated socially economic value. See, social economic. So it's not merely hard numbers within the silo of your pathology. It goes broader than that. I will go into a little bit more on that later. And once you have M1 and M2, you can submit the dossier in order to request reimbursement or financing, depending on what term you want to use, of the patient trajectory. So it's not necessarily only the application. We are talking about the complete patient trajectory here. And you will see this being reflected on the description. You will need to describe the patient trajectory with the application, without the application. You will show, you will have to show the role and the value of the mHealth technology within that care pathway. So you can see that they are looking at the total picture, and this is being absolutely being reflected if you look at the budgetary impact, that they allow transversal effects. They allow you to look at other effects that are secondary towards your application, and you can note them down in your file, and they will look at it. Note in Belgium that this is not the only way to get reimbursed. You can have financing of hospitals themselves. Some of them have specific programs, And some health insurance companies within Belgium reimburse applications that are on mHealth Belgium and are being prescribed by a medical doctor. I hope this is more or less clear. I can see that I'm going a little bit over time, but so I will try to finish here. And that is that this is a high-level procedure. So you will do an application or a notification of your application on the working group telemedicine. Then in turn, they will have a specific working group that will look at your dossier, and they will give an advice to the highest committee in the Risief Inami in Belgium, meaning the insurance committee. The insurance committee then will take a decision in order that they will have reimbursement or not. This can take quite a while. This is really noted very small, and this is not that I'm not want to be transparent on this, but just I didn't get it blown up bigger, but it will take at least 6 months. Okay, so this is how it will look like, or how it looks like. We have the first dossier for the moment now. So the specific work group is being made as we speak. As Agoya, I'm part of this working group, and we will look at it. So this will be the first precedent, on the first, if it comes through, the first application that goes for an M3. There are some things that aren't really clear due to the fact that it hasn't been done as far as we know yet. So the first one will take place this year, and I'm very curious, as probably you are as well, on how this will further develop. Know as well that this isn't set in stone, meaning this is a subject of continuous negotiation, continuous change, so they can optimize this process later on. So keep this in mind. They will publish this, and I will be the first one to let you know if this happens, but be aware of this. In summary, 3 levels are available right now, and then I can stop here and give the time back to all of you. Sorry to go 5 minutes over time. I hope we can discuss further on if necessary, and I'm open to all questions.
Thank you. There are actually 2 questions. I think one question you kind of answered at the end. How many applications have reached level 3? I think there's the first one that is in the making. Is that correct?
Yes. I will be very fully complete here because some of you will know this. There is a pilot project of Move Up, and they are reimbursed. This was in the mainstream media entirely, so not only in the specific media. So this was really to the broad public, which was really good, but it gave a little bit of a misunderstanding. So this isn't a clinical study. So they are the first. Well, yes, but it's not M3 as so far. They will not look at it as such either. However, they are reimbursed, but the really official one, now the first is in the starting blocks, I would say, and we'll see the results on how the specific work group will look at it and what the advice will really be.
Thank you. I think we can dive a little deeper into the timing question, because there also has been a question like this similar to Jonas. I'd like to introduce the speakers that have been patiently waiting. I think because they're not sharing kind of facts, but they're true experiences. And first of all, I want to congratulate Jonathan, because you just raised 1 million to internationalize your company. And I think one of the topics for sure is entering different markets, and maybe also entering Germany. And we will talk about that. So Jonathan Schreiber, co-founder and CEO of Neuroventus, and you have 2 products, and feel free to also explain a little bit more what you do. And then there's Julian Gansen, that also joined from Germany at MSense, and I think you're one of the 15 DIGAs that already have been approved, and I think you joined the company 2 years ago and have been part of that project for all the time. Maybe we can quickly introduce what you do exactly and in what status you are with the DIGA application or your certification. Maybe Jonathan, you want to start?
Yeah, thank you, Maren, for the introduction. Hi, everyone. So my name is Jonathan. I'm co-founder and CEO of Neuroventus, which is a Belgian startup. We develop digital health tools in neurology. for patients and their healthcare professionals. So our first product is in epilepsy, where we provide patient empowerment solutions through monitoring and self-management tools. We're currently active actually in several EU countries. So thanks to the investment of a couple of months ago, we're a team of around 20 people. And in terms of market access, which is a bit the subject here, our focus today is on our epilepsy product in Germany with the Digital Care Act. And so why is that? I think Jonas laid it out quite well. The process is very clear, so there's clarity there, so you know what you can expect. Also in terms of timing, there's a very innovative character, and they support the first year to provide gold standard proof, RCT trial or something else. And then third point, also quite important, the market size of Germany is big. And so it's the biggest market here in Europe. So in terms of either way, for any country, it's going to be a lot of effort to get reimbursement. So in terms of market size, the return on investment is expected to be highest in Germany. So we've been working on that actually for a couple of months on our Digital Care Act submission. It takes some time, as Jonas said, so we're still working on it. We're still getting there. But yeah, so that's very basically where we are today and what our focus is and why we focus on Germany. Thank you.
Julian is there already, so maybe we can also hear some more, best practice do's and don'ts. What you experienced, Julian, when you put MSense to the process that looks very complicated, but I think within a year you made it and you're part of the fast track now.
Yes, definitely some do's and also some don'ts. As we were one of the first movers. I think we were the 7th of all DIGAs approved as preliminary listed. Maybe a few words like to our background or to my background. I'm the director of market access at Nuisance Lab. I joined 2 years ago, and on my second day, the first draft of the Digital Care Act was released. So I had the pleasure and pain to accompany this process very early on, even when not all stakeholders, even on the government side, were actually sure about how to interpret certain things. So this was a very funny process. But then we applied, I think in September 2020, and got approved as preliminarily listed in December, on December 16th as the 7th DIGA. With MSense migraine as a native app for both platforms with a treatment intention as a medical device, of course. Yes, and now it's very interesting also to be here and to talk about this and to listen to Jonas and to Alexander, because for me, I've been focusing now. We're at the stage of focusing of informing physicians and patients about how to prescribe MSense. So, but it's very interesting flashbacks to the time between let's say March and December 2020, where we actually were in the application process, which was very, very exciting. That's where we're at.
Jonathan, in which stage are you right now? Because Julian, also I think within like 12 months you said you made it, and Jonathan, because there is a lot of questions about how long does it take and how much time you have to invest in that. I'm not quite sure if you could share a little bit the story behind your application right now.
Yeah, so we've also learned a lot about, so in the past couple of months, so we started really working on it during the summer of last year, so quite a long time ago. We actually learned about the process. So there was still a lot of, in Belgium, Jonas mentioned it, telemonitoring is seen a bit differently than in Germany. So that was also a link point. You focus on the patient. We have to create value directly for the patient. So that was a learning point for us. And so then we gathered a network of people around us, physicians, to prepare the evaluation concept, so the clinical protocol, etc. And then people that have been working, like Jonas, he's been helping us over the past couple of months, and his team to work on this. So now we're at the stage where we're finalizing the evaluation concept. So that's basically the two big things: that the general requirements. Those are like medical device, GDPR, etc. So that's something that was relatively easy for us, because that's something that we already complied with. But then the second part, the evaluation concept, this takes more time because you have to really think through about this, what you want to take as endpoints in your study, what you want to prove. So we're currently in that phase, preparing that evaluation concept. And one of the stages that also quite takes some time there in the evaluation concept is generating some data. So BfArM is expecting data, preliminary data on the use of your DIGA or your platform in a real life setting, and have already some proof that it's going to work. And that also can take some time. So we're also working on that. So that's currently the stage where we're at.
There has been one question actually during the presentation of Jonas, and maybe Jonas and Alexander can also join, because I think internationalization is a big topic here. One of the questions from Antoine was, could you elaborate a bit more which stakeholders you need to work with to show the benefit? Like, what do you have to do? Could you actually take evidence or data from a different country and kind of, apply it? I think for you, Julian, being in the biggest healthcare market in Europe, I know that France is also moving into that direction, a few other countries. It will be relevant as well, even if you are from Germany and want to kind of expand across Europe. Is there like a pattern you can see? Is there something you can use, some benefits, having the status in Germany to move to Belgium, or, coming from Belgium to Germany?
I think there are two things to consider if you want to apply for a DIGA as a company who is not located in Germany. I think the first thing is your study. I mean, the DIGA says the study should be conducted in Germany, because also affect that the natural setting of the healthcare system will sort of have an effect in a real world setting where people who use a DIGA usually are. But there is also the part in the law that says, okay, but if you don't have that, if you have a study in another country, you have to justify why this is comparable. And I think this depends a little bit on the healthcare systems, on where you and the patient population, if it's comparable, if the system is broadly comparable. For example, if you have, I don't know, if taking medication or adherence to medication plays a role in your DIGA, then the medication that are actually on the market should sort of be comparable, for example, in these different healthcare systems. So these are the things to consider. But I think, I'm not sure, because I haven't, maybe Jonas can enlighten us on that, or Jonathan, but I think it might be possible if you have a study in other European countries with similar healthcare systems, that you can have that you have some sort of statement from an expert that says that this should be comparable. The second thing I think that's important is the medical device regulation. I think you need an entity in Germany that is the responsible person or entity for your medical device that is brought into the market in this country, if I'm not mistaken. But I'm not sure how that is changing, because I'm reaching a little bit my limit in knowledge about medical device regulation here.
If I could just add directly to this, I think there was a fantastic explanation. And also, you're completely correct. You need a distributor in Germany, or you need to have a part of your company in Germany. These are the two options. Although usually founding a GmbH, a capital-based company in Germany, is usually the way to go, because it's easier. And actually, this was an excellent question from Anton regarding the evidence from abroad. That becomes a bigger topic. We have a lot of a lot of different cases regarding that. And I mean, there's no clear rule, because the BfArM will make a case-by-case decision, but a rule of thumb is you need a very comparable healthcare system, and the care reality has to be the same. And single expert opinions are usually not enough. You kind of have to write a small essay on why my country or my patients are treated the same. And usually the backbone is care provided in the same setting? Is the population roughly the same representative? And is the treatment algorithm and the intensity of care comparable with Germany? Because if you have in general much better cared for patients, then your DIGA might have a higher or lower effect, and then it's not comparable anymore. But in general, we only have one case of precedence where a Swiss-based study was used, but only for the preliminary evidence, applying for a final listing with evidence that not from Germany. That's technically possible, although I would strongly recommend against it, because the BfArM has, they're quite hesitant when it comes to that. But having a proper study that you did abroad to use as info or input for preliminary listing, that's good. However, the vast majority of startups fails in that regard to have the product still be similar enough to the one they used in the study, because usually development goes faster than you can actually provide the evidence. And then the BfArM says, well, we do not accept this type of evidence even for the pre-study, because you added features to your DIGA or the DIGA relevant software, and so on. So that's kind of the status quo currently for the foreign manufacturers we accompany.
I also know that a lot of documents in Germany for DiGA are in German. It's quite different than what you also said, Alexander. But I wonder if you see the Belgian market, because you also said on purpose, the multi-language platform that gives a lot of transparency. But at the end, you also see a lot of at least European-based rules and requirements. So is that kind of international outreach mainly focused on Europe, or is there also an opportunity for other kind of international companies from the US, from Asia, to actually apply for the Belgian reimbursement scheme? You're still on mute.
Could you re-ask the question, because the connection is falling here?
Yeah, I said the platform is on purpose in English, but on the other hand, if you see the requirements, they actually very much focus on kind of rules and data that applies to Europe. Is it still possible for companies outside of Europe to apply? Same discussion what we had for Germany.
Yes, as long as they have the three first criteria, meaning M1, the GDPR as a medical device, the auto declaration on GDPR, and they do the notification at the federal agency, they're good to go. There are less requirements on the entire field of where you're based and so forth. And this is one of the reasons too that the website is in English, partly in English as well. If you want to go to more, the higher up you go into the pyramid, I would say the connection with the country itself becomes increasingly important. For M2, and I think their companies outside of Europe will have an extra difficulty in order to understand the Belgian system, at least. I had a discussion with Julian last week, that the Belgian structure is so complex or so in its own that understanding the healthcare world within Belgium is already more or less necessary. And then thirdly, you have to file where you are located and so forth. But as for now, there are no really hard requirements on where you have to be based.
Just a heads up for anybody that joined, use the chat or also raise your hand if you want to ask a question. All the experts and the startups are here to actually share their knowledge. So please use it as well. A question for you, Jonathan, and I think that refers to what Alexander just said. You mentioned in one of the pre-talks that you actually do 80% of your business outside of Belgium. So, how does it look like? Is there kind of evidence-based activities in other countries, and what do you do exactly in Germany?
Yeah, so in Germany, our focus is really on epilepsy, on the Digital Care Act. So why do we focus on Germany? As I said, unfortunately, compared to Belgium, the system is much clearer. So there's less uncertainty, and Germany is willing to help you in that first year when you have to prove the value, the scientific value of your solution. That's really innovative. That's something that Belgium doesn't have. So that's why we focus on Germany. And maybe on that side, what's important, I think that what Julian is maybe experimenting now, that's his focus now is, once you're on the German market, once you're listed, you also need to get those healthcare professionals use your solution, prescribe your solution. And so that's also what we're working on. So we're not only working on preparing the technical side of our submission to BIFA, but also preparing our go-to-market strategy once we're listed. Because it's nice to be listed, but if no healthcare professional knows about you, wants to use you, then it's just effort that you're going to waste on administrative and technical stuff. But here, curious about Julian.
Maybe a point there that I can add on Jonathan, because he makes a very good point, a very solid point here that I tend to give to all of my member companies as well, is that the reimbursement, at least in Belgium, and for Germany, I think this is more a strategic choice for the company. But if I look into Belgium and just solely being after this reimbursement and putting all of your eggs in that basket, as we used to say, I think that is a very hard or dangerous choice. And I think Jonathan is saying the right thing there, that you have to convince the entire ecosystem of your project. And so you're less dependable on whether you will have this reimbursement or not. It makes you more independent as a company, it will make you more successful as a company, and it will make you more reliant and resilient as a company. If you go into this broader way of marketing in the next level and doing this instead of just sitting there and waiting for your reimbursement file to come through, I tend to see from my perspective, where I can see quite a lot of companies in a very short time, that those aren't the ones that are hugely successful. It's more the ones that go after every point in the entire value chain, and those are the ones that are successful. And this, I think, and correct me if I'm wrong, Jonathan and Julian, but I think this is applying for all other countries as well. Get to know the healthcare system and go after every individual point in there, or value point in there, and then you will succeed. And then if reimbursement comes through, you have this great add-on, I would say, but you aren't dependent just on that point.
Maybe to add to that real quickly, I think it's important as a manufacturer, if you have products in the digital health space, right? Digital health can be very broad, as we see, for example, Belgium, it's way broader. It's defined in a much broader sense. In Germany, DiGA is very narrow. You have to have what Jonas nicely said. You have to patient focus. You have to and has a purely digital modes of action, so to say. And within that space, then you need to have a study that compares interventional studies. So basically, but it's very narrow. That excludes a lot of solutions, right? For example, it excludes solutions where the physician is tightly integrated. It excludes blended care solutions. It is very exclusive, so to say. But if you think about your products and basically, or if you have a product, if you want to develop products, you always have to think from the business model, right? What's the business model? Who pays the money? In Germany, DiGA is reimbursement focus. You have a product in the market that has to be effective, and then you have prescribers. You have another way via direct reimbursement via the health insurances, which is a little bit different. So, but you have several ways, but it's always reimbursement. In Belgium, you can be more creative, right? You can have, for example, if I understand that correctly, you can have along the value chain, you have different payers that can pay you money for your solution. So you have different customers for your value that you create. And with DiGA, it's very closely defined that the money, where the money comes from, whom to create the value for. So I think this is important to consider when you have a product and want to access a market, or when you're thinking about developing a product.
Jonas is nodding, so I think he agrees. There's also one question for Julian and Jonathan, and I think one is knee deep in there, and the other one is kind of also learning how to do that. How do you get the healthcare professionals to prescribe your product? What are the hacks here?
I don't know, Jonathan, do you want? I mean, I can. Since I'm currently knee deep in this challenge to getting healthcare professionals to prescribe with very small budgets. Also, to be honest, I mean, let's just say it depends where you come from. I mean, maybe it's a very broad sentence. It's just marketing and sales, so don't be afraid of that. And the only ones who currently have experience in this is not startups, because you usually have never done that, because it was never added never really any value to your business. But for example, look at pharma companies who do that all the time. And look at medical device manufacturers who do that all the time. And but the target groups are being a little bit different. And then basically you can do what they do, just on a smaller scale. Or you could partner with them, for example. And you can choose distribution partnerships. I think, for example, in the DiGA space, there are a few distribution partnerships. One of the first, Calmeda, is partnering with Paul Boskamp. And Deprexis has a partnership with Servier. And then you basically get you pay money, or you give away parts of your revenue, depending on the model that is agreed upon. And then, of course, you get less money, but you get a higher number. And then it's up to you to make the trade-off and to calculate, is that worth for you? And is it possible for your distribution partner to achieve those numbers with the classic sales measures of a pharma company, sales reps, et cetera, et cetera, et cetera. If you don't do that and you do it by yourself and you have smaller budgets, I mean, of course, there are several ways you can start from that usually also pharma does. You can do print mailings, you can KOL management, all these different types of things. I think the important thing is to prioritize and to think, okay, what are your strengths and where you can actually create value with your sales measures, because this is completely new for like startups in this space usually, and you have to either buy it, or you have to hire people who know about it, or you have to have the willingness to go knee deep and to actually try to hack it somehow.
Jonas wants to add something. Just be aware we have like 2 minutes left, and there will be a last question about the hack, like the life hack on a daily basis you would recommend to any startup that wants to do it. So I will do the round, but Jonas, you wanted to add.
Just very quickly, one thing. I think what Julian said was very valuable, and that's currently after getting into the registry, that's the biggest bottleneck. And there are 2 other ways that we're currently also exploring with startups. Julian's way is the proper one and definitely the safest one. Other ones are go via the Fachgesellschaften, so the expert groups of physicians. When you find champions there, they disseminate their knowledge there, and also through their training programs, they can disseminate the DIGA there. And the third option is there are these mandatory training courses that doctors have to do, and currently several of the industry groups, for example the Spitzenverband Digitale Gesundheitsversorgung, does these also to disseminate the knowledge. In general, it's important to see, is your patient population approached by a doctor, or are they suffering a lot, for example like obese patients, and you can approach them over social media, and then they approach their doctor, please prescribe me the app. If you figure this out, you can define the angle of approach. Thank you. That was it.
So 2 hacks already, one from Julian, partner wisely, one from Jonas. Jonathan, what is your hack you can recommend to the startups listening in?
Yeah, so we're still working on it. And I think what Julian said is, and Jonas, how they complemented is quite nice. You can work on patient side, you can work on physicians, you can work on existing organizations. So I actually don't have anything to add. I actually maybe have a question for Julian. How painful is it to get physicians to is the interface technically, is it easy for physicians to do it, to prescribe a DIGA or
This is actually very easy, because that was a very wise decision to start with paper. So they just use the Muster 16, like the Form 16, where what they usually use for drug prescriptions, and they just write them. You can even with your handwriting write the name of the DIGA and the pharma central number on it, and then you're good. So this is actually quite easy, but you will get a lot of fax answers back if you engage with physicians. So be prepared to process a lot of faxes.
Another hack, Form 16. Write that down. Alexander, what is your hack that you could recommend to enter the Belgium system, or also thinking about internationalization?
I think more of a general advice that I want to give is the fact that understand the care pathway completely, from the beginning until the end. I see too many companies that do have a value proposition, they have a solution, but they don't understand completely or entirely what they are trying to solve really. And so really understand the complete care pathway.
You're on mute now, Alexander.
Yeah, sorry, because they are just working here next to me. I'm sorry. Understand the complete care pathway. And once you understand that and identify all of your value partners, and if you understand all of those, see how you will click it in within Belgium or another landscape, and see where you can find your hangers at least to build on or hang on your solution. I think that is most important. So you understand everything across the entire lineage of the patient way.
So I think your message is do your homework.
Yeah.
Thanks all for joining. A few of you asked if we are going to share the slides and the feedback. Yes, the session has been recorded. There are also sessions coming up, and I'm quite sure that Alexander and Jonas are also joining other events and sharing also their email addresses and the contacts. Also check out all of the speakers on LinkedIn. And there are one-on-one sessions coming up today and tomorrow, and I think it's also a great opportunity to dive deeper into any very specific questions you have. For sure, we could not cover everything in 1.5 hours, but I think we hope to start the conversation and continue that conversation later on. And thanks for all the organizers, and I see Jessica joining. So I hand back to you, Jessica, and to you, Lise.
Yes, also from my side, thank you all for joining this online event. And as Maren already said, so the one-on-one meetings are going on now. So if you haven't booked any meetings, have a look at it. And I hope we will stay in contact and will talk to each other again just contact us with all your questions regarding the Belgian or the German market. So thank you, and good, as has been said, partner wisely. So please make use of the B2B matchmaking, and yeah, thank you.
Thank you.
Thanks a
Bye
lot.
bye.
Bye bye.
Thank you. Bye.